and welcome to another episode of Today's Medicine. I'm Dr. Hugo Pellegrinolo, and today I'm going to be talking about Ecmo and also about some aspects of the life of actor Matthew Perry that portrayed on the TV series Friends, Chandler Muriel Bing. As always, thank you very much for watching today's episode, and as always we do have English, Spanish, Portuguese, French, and Ukrainian subtitles. Matthew Langlois Perry, born August 19th, 1969, is an American-Canadian actor, comedian, and producer. He's best known for his role as Chandler Muriel Bing on the NBC television sitcom Friends from 1994 to 2004. Matthew Perry became addicted to Vicodin after a jet ski accident in 1997 and completed a 28-day rehab program later that year. His weight fluctuated drastically over the next few years and once dropped to 145 pounds, 66 kilograms. He lost 20 pounds, 9.1 kilograms in the year 2000 due to pancreatitis. He again entered rehab in February 2001 for addiction to Vicodin, methadone, amphetamines, and alcohol. He was filming Serving Sarah in Texas when he suffered severe stomach pains and flew to Los Angeles to check into Marina del Rey's Daniel Freeman Hospital. Perry's publicist, Lisa Casteller, confirmed his rehab stay. He says he has spent around $9 million to get sober. He has revealed that due to his addiction issues, he does not remember 3 years of his time he was acting on Friends, somewhere between season 3 and season 6. In 2011, as the celebrity outspokesperson for National Association of Drug Court Professionals, Perry went to Capitol Hill to lobby members of Congress in support of funding for drug courts. Perry received the Champion of Recovery Award in May 2013 from the White House Office of National Drug Control Policy for opening Perry House, a sober living home situated in his former mansion in Malibu, California. Perry later sold the home and shuttered the rehab center in 2015. Perry has been completely sober since 2021. In August 2018, it was reported that Perry had abdominal surgery to repair a gastrointestinal perforation. On September 15, 2018, he revealed in a tweet that he had spent 3 months recovering in the hospital, suggesting that the surgery had taken place in June 2018. He then became engaged to Molly Hurwitz, a literary manager, in November 2020. In June 2021, Perry announced that he had called off the engagement, telling People magazine, "Sometimes things just don't work out, and this is one of them. I wish Molly the best." During the time in which Matthew Perry underwent hospitalization for his gastrointestinal perforation, he had to use a device called Ecmo for a few days. Extracorporeal membrane oxygenation, also known as extracorporeal life support, is an extracorporeal technique of providing prolonged cardiac and respiratory support to persons whose heart and lungs are incapable of providing the adequate amount of gas exchange or perfusion to sustain life. The technology for Ecmo is largely derived from cardiopulmonary bypass, which provides shorter-term support with arrested native circulation. The device used is a membrane oxygenator, also known as an artificial lung. Ecmo works by temporarily drawing from the body to allow artificial oxygenation of the red blood cells and removal of carbon dioxide. Generally, it is used either post-cardiopulmonary bypass or in late-stage treatments of a person with profound heart and/or lung failure. Although it is now seen used as a treatment for cardiac arrest in certain centers, allowing treatment of the underlying cause of the arrest while circulation and oxygenation are supported. Ecmo is also used to support patients with acute viral pneumonia associated with COVID-19 in cases where artificial ventilation alone is not sufficient to sustain blood oxygenation levels. Guidelines that describe the indications and practice of Ecmo are published by the Extracorporeal Life Support Organization. Criteria for the initiation of Ecmo vary by institution, but generally include severe cardiac or pulmonary failure that is potentially reversible and unresponsive to conventional management. Examples of clinical situations that may prompt the initialization of Ecmo include the following: hypoxic respiratory failure with a ratio of arterial oxygen tension to fraction of inspired oxygen of minus 100 milliliters, despite optimization of the ventilator settings, including the fraction of inspired oxygen, positive and expiratory pressures, and inspiratory to expiratory ratio. Hypercapnic respiratory failure with an arterial pH of minus 7.2, refractory cardiogenic shock, cardiac arrest, failure to wean from cardiopulmonary bypass after cardiac surgery, as a bridge to either high transplantation or placement of a ventricular assisted device, as a bridge to lung transplantation. Septic shock is a more controversial but increasingly studied use of Ecmo. Hypothermia with a core temperature between 28 and 24 degrees Celsius, and cardiac instability with a core temperature below 24 degrees Celsius. In those with cardiac arrest or cardiogenic shock, it appears to improve survival and good outcomes. Use in COVID-19 patients. Beginning in early February 2020, doctors in China have increasingly been using Ecmo as an adjunct support for patients presenting with acute viral pneumonia associated with SARS-CoV infection, when with ventilation alone, the blood oxygenation level is still remain too low to sustain the patient. The initial reports indicate that if it is assisting in restoring patients' blood oxygenation saturation and reducing fatalities among approximately 3% of severe cases where it has been utilized. For critically ill patients, the mortality rate reduces from around 59 to 71% with controversial therapies to approximately 46% with extracorporeal membrane oxygenation. A March 2021 Los Angeles Times cover story illustrated the efficacy of Ecmo in an extremely challenging COVID patient. In February 2021, 3 pregnant Israeli women who had quote-unquote very serious cases of COVID-19 were given Ecmo treatment, and it seemed this treatment option would continue. Early studies have shown survival benefits with use of Ecmo for people in acute respiratory failure, especially in the settings of acute respiratory distress syndrome. A registry maintained by also nearly 51,000 people that have received Ecmo has reported outcomes with 75% survival for neonatal respiratory failure, 56% survival for pediatric respiratory failure, and 55% survival for adult respiratory failure. Other observations and uncontrolled clinical trials have reported survival rates ranging from 50 to 70%. These reported survival rates are better than historical survival rates. Even though Ecmo is used for a range of conditions with varying mortality rates, Early detection is key to prevent the progression of deterioration and increase survival outcomes. In the United Kingdom, venous Ecmo deployment is concentrated in designated Ecmo centers to potentially improve care and promote better outcomes. Contraindications. Most contraindications are relative, balancing the risks of the procedure versus the potential benefits. The relative contraindications are conditions incompatible with normal life in the person recovers, pre-existing conditions that affect the quality of life such as central nervous system's status, end-stage malignancy, risk of systemic bleeding with anticoagulation, age and size, and futility. Those who are too sick, have been on controversial therapy too long, or have a fatal diagnosis. The side effects and complications. Neurologically, a common consequence in Ecmo-treated adults is neurological injury, which may include intracerebral hemorrhage, subarachnoidal hemorrhage, ischemic infarctations in susceptible areas of the brain, hypoxic ischemic encephalopathy, unexplained coma, and brain death. Bleeding occurs in 30 to 40% of those receiving Ecmo and can be life-threatening. It is due to both the necessary continuous heparin infusion and platelet dysfunction. Meticulous surgical technique, maintaining platelet counts greater than 100,000 per milliliters, and maintaining the target activated clotting time reduce the likelihood of bleeding. On the blood, heparin-induced thrombocytopenia is increasingly common among people receiving Ecmo. When hepatic-induced thrombocytopenia is suspected, the heparin infusion is usually replaced by a non-heparin anticoagulant. There is retrograde blood flow in the descending aorta whenever the femoral artery and vein are used for venous arterial Ecmo. The status of the blood can occur if its left ventricular output is not maintained, which may result in thrombosis. Bridge to assist device for venous arterial Ecmo, whose cardiac functions does not recover sufficiently to be weaned from Ecmo, may be bridged to a ventricular assisted device, a VAD, or a transplant. A variety of complications can occur during cannulation, including vasoperforation with bleeding, arterial dissection, distal ischemia, and incorrect location. And lastly, infections. The prevalence of hospital-acquired infections during Ecmo is 10 to 12% higher when compared to other critically ill patients. Coagulose-negative Staphylococcus candida, Enterobacter, and Pseudomonas aeruginosus are the most frequently involved pathogens. Ecmo patients display a high incidence of ventricular association pneumonia, 24.4 cases per 1,000 Ecmo days, with a major role played by Enterobacterium. Infection risk was shown to increase along the duration of the Ecmo run, which is the most important risk factor for the development of infections. Other Ecmo-specific factors predisposition to infections include the severity of illness in Ecmo patients, the high risk of bacterial translocation from the gut, and Ecmo-related impairment of the immune system. Another important issue is the microbial colonization of catheters, Ecmo cannulas, and deoxygenation. As always, thank you very much for watching today's video. If you have any doubts at all, you can always send me an email to hugo.loh@gmail.com. As always, thank you very much for watching, and don't forget to subscribe to the channel.